We're going to jump around a little bit. Today's in-service is mainly on the Zoll Defibrillator. We're going to cover a couple things and then lead into the Zoll, and then a couple things after the Zoll. One of the first things we want to talk about is what happens when something happens. What do we do? The first thing I want to tell you is both of our crash carts are now in the hallway right outside of packing, right in between the two doors that open to go into the operating room. The taller one that is multicolored is our pediatric cart. So it's nice to know the difference of which one you bring into the situation. The shorter one is our adult cart. The pediatric cart, when you bring it in, has a slightly different setup. Both of them are complete for a code, but the pediatric cart, when you bring it in, the really important thing, whoever's bringing it in, and you crack that cart, there's something called a Braslow tape, and that's one thing we really need to pull out from the beginning. Just pull that out. Whoever's bringing the cart in, crack it, pull that out, and put it up beside the child. Okay? When something happens, such as a code or whatever, obviously you know to pull the code switch, let the ologist know, let the team know. Shout for help, obviously. I know you know your BLS, what you should be doing there, but in each space it's a little bit different. In pre-op, in the operating room, and in the recovery room. I think it is very important within each space that immediately roles are defined. Okay? In the operating room, it's going to be a little bit unusual because we'll be a little bit busy at the head of the table, either securing an airway, preparation for drugs that need to go in. The ologist needs to be called immediately. But I think it would be a good idea, whoever the circulator is to immediately take charge until things settle in, the ologist gets in there, and we've got everything secured. So as the 150 people crowd into that 10 by 10 room, make sure that you're telling people who we do not need just to exit, because everybody else in the building needs care also. But to define roles. Say, Joe, if you were the circulating nurse in there, Lord help us. And bring the milk bucket. As people are coming in the door, the nice thing would be okay, I want you to record, I want you to go get the crash cart, I want you to record drugs, so there is a defined role. And I think
I'm going to interrupt from time to time if that's okay.
Yeah.
So, and also too, number one thing I think is that we all kind of get wrapped up in what are we doing? We're scrambling to get things, but you always got to remember there's no ACLS, so there's no advanced cardiac life support without BLS. Okay. So number one, we know somebody needs defibrillated. We know we need airway management. We got all that, but somebody has to be doing CPR in the meantime. So and I think it's easy to forget because everybody's kind of scrambling doing stuff. So, okay, somebody needs to be on the chest. So, go ahead.
And that's true. And per BLS, which all of y'all know, chest compressions are the main thing now. We try to start that from the beginning and then continue on without interruption. Once roles are defined, when people get in the room, as quiet as it possibly can be is the best thing, to have one person calling out what needs to be done, and most of the time that'll come from the head of the table after things are settled a little bit there. The other thing I really want to stress is tensions are high, but it's best, and that's why it's best to keep it quiet, and best to keep one or maybe two people who are given kind of commands of things to do. But I think we always, in that situation, there has to be an element of respect, okay, with everybody. No barking, no, not that any of us do that, but, I think there has to be an element of kindness in a code, to where we're not belittling or challenging or whatever. Not that if something's wrong, it shouldn't be challenged. It should be, because that's what we're all there for. We're all there for each other.
Don't walk out if your feelings get hurt.
That's right. There you go. In the recovery room, things are a little bit different. You've got a lot of nurses right there, ready to go. Hopefully, a CRNA may be taking a patient in there. But you guys know, just to call the ologist, get going, and everybody's going to come running. Same with pre-op. Do we have an AED in the building? Do we know? Or do we just go off of our defibrillator?
We're using this one.
This is it does work as an AED.
Yeah.
It does,
Yeah.
but I just didn't know if there was one out front that we didn't know about. Okay. All right, and we'll talk a little bit about that at the end too with that. So, once you get chest compressions going, the airway's secured, things are going on up there, somebody asks you to bring the the defibrillator in. This is the Zoll, and it's the R series. It's a little bit different than what's in our book, but we'll go over some of the commands. This is really kind of a neat little machine. It does several different things. It defibrillates, it cardioverts, it paces. All of your modes of what you can do. Can you guys see it all from where you are? If I get out of the way. This is kind of your control switch of what you do. It's going to be set on off when you bring it into the room. We already have, hopefully, in a lot of situations, the patient on a monitor. But in pre-op, if they're not on a monitor or whatever, and there's a scramble to get it, or if they're in the lobby and God forbid something happens there, you do have a way to monitor. That if you just put the leads on, and everything comes with it, these are your EKG leads, if you just put those on, it will monitor. It'll monitor whatever rhythm you give, whatever rhythm they're in. And you can change leads up here. You have the soft buttons over here. You can change leads. You can change the size. You can suspend the alarm, which I wouldn't recommend you doing, or you can hit a record, and that's going to record whatever rhythm they're in. In the defibrillation mode, if you go out there, there's no pulse, they're doing CPR, you put it in, they're in VFib or VTAC, you just shift it over into the red mode. And you guys can walk up and look at this if you want to get a little closer at this time, or look at it as you pass through the hallway. The defibrillation mode, this is a biphasic defibrillator. It does a little bit different than the other defibrillators. This one will start at 120 joules. I know we're all used to 200, 300, 360. This will go 120, 150, and what's the third? 200. 200.
So, and is there so between monophasic and biphasic, monophasic is kind of old school, everything is biphasic now, but monophasic is just kind of from one side, like one charge comes out, okay, so it disperses. So it's kind of general, not really specific, okay, so you need more energy that way. If it's biphasic, you have a paddle in front and a paddle in back, so the impulse comes out, bounces off and comes back. So you need less current to do the same thing.
No, you're good, exactly. And it's okay, like we were talking earlier, to use more current. More current's not gonna hurt. At this particular time, it's determined that the patient's in VFib or whatever. There is a charge button right here. You hit the charge button, you will hear it come up. It'll say charge. At that point, you make sure everybody's clear, okay, except for Judy. Make sure everybody's clear, and then you charge it, okay? Can you shock them again? Okay. Can you shock them a third time?
Sure.
Okay. Yeah. But once you get up to that, the top of your range for joules, you really don't want to keep going off of that. You can just keep shocking as often as you need to.
If you're going to cardioverter, the sync button won't show up on this machine until you're in the defibrillation mode. Okay. So if you're trying to cardioverter somebody, that won't show up. It'll show up on one of the soft buttons at the bottom, but that won't be till after you're into the defibrillation mode. Okay.
So what Joe's showing you, you put them on the monitor and you're getting ready to do a cardioversion in the post-op area. And you just have it on monitor, you're going to be looking around going, where is my sync button? The sync button doesn't arise until you put it into the red zone. Okay, and then it is a soft button on the bottom here on the far right, and it says on and off. Now you want to sync just because you don't want to shock on your R wave. But that is not a good thing. You should throw them into VTAC. We can also, with this particular monitor, we can pace. With pacing, you go into the green zone, you have an output button down here, and you have a rate button down here. The output button, generally we start somewhere around 30, and you just work it till you capture. You just work it till you capture. And everything's kind of preset with it as far as rate, it's set at 70. You can change that with this button, whatever you need to do with that to cause it to capture and get them back. Do we shock asystole?
No.
Okay. All right, so pads, as Joe kind of talked about a little bit earlier, each of our defibrillators comes already attached to it pads, okay? They find, as Joe was saying, that a biphasic works much better by using the pad system. If you notice, we don't even have paddles on these right now. There is a space for paddles, but we don't have paddles. You get greater conductivity through the pads because of the gel, because of proximity, the fact that you don't have soft areas where the paddles are not touching the skin. But you'll have to roll the patient. One of the pads comes down, as you see right there, kind of a little bit to the side, lateral to the sternum and below the nipple line. So it's kind of right where you think the heart would be, and that's where you want to go. The back pad will go onto the back. The one thing I want to really impress upon you is do not put it on the scapula, because there's a reason. It's not going to conduct as well through the scapula. So you'll come a little bit medial to the scapula when you put that on.
If you can't roll for some reason, you can do.
Yes, you can. You can. You can. So if we have a pediatric patient and this is brought in, can we shock a pediatric patient with this?
Yes.
Okay. Can we shock an adult with a pediatric pad?
Sure.
Yeah. Whatever you got, you can do. This is kind of a neat little machine too. On the top bar there's several different things that are indicated for you to make sure that what you're doing is facilitating this person's need for life. This particular device right here is a CO2 monitor. It will attach into an ambu bag or it will attach into our circuit. Obviously, it'll only fit one way because one's bigger than the other. Your CO2 will show up on here and allows you to know if you're getting good compressions, if you're getting good ventilation. The other thing that this does is with CPR, it shows depth and it shows rate. And it can say whether you are deep enough or whether you're fast enough. So you have little indicators here that will help you with that. Anything else you want to add about this machine?
Quick question.
Yes.
I think it's recommended, isn't it? I know, like in the OR or in pre-op, if the patient is already being monitored, but to switch them to those leads, isn't it? Put them on that monitor rather
If you
than
have to pace them.
Yeah, if you're gonna pace.
only the patient.
If the patient's
Yes.
doing this.
Or
So-
if you're going to synchronize. If you're going to synchronize for a cardioversion or something
So
like
as a
that.
general
or if you're
rule,
gonna pace.
if you have time, probably it's best to switch them over, just like you said. Yeah.
Okay.
And you don't have to switch them over. You
Okay.
can just
Right.
pop these beside the other ones.
Okay.
Does that make sense?
Yeah.
Okay. But for defibrillation, unless you need analysis, unless you need to see if it's, it's saying it's VPAC or VFib, then you do not need to use those leads. You can just come in and if it's a quick shock thing.
And just like you said, there's an analyze mode on there, so it's an
Yes.
AED as well.
Yes.
Okay, so, yeah. So there is an analyze mode to put it on there, and it'll advise you, just like the AED, like wherever that it says, advise you shock or no shock
Right, with the pads.
with the pads.
Yes.
Correct.
The
And
pop
if
With the
you're-
pads.
pads.
Right, and
Yes.
if you're doing CPR at the time, you have to stop to let it analyze, because that would be too much interference.
Okay.
So,
There's no connection with this thing to your machine though, is it?
There was rumor when we first got this, you mean to our
To your
monitoring
anesthesia
system?
machine, so
Or you mean to Epic?
No, I'm saying to your anesthesia machine, so if we take them off of your machine and put them on this, then that is your record of what you're doing, basically.
Yeah, I would never take them off of our
Yeah,
stuff.
so-
Number one, because our monitor feeds into
Yeah.
Epic, and that's a story that we don't want
There'll be
interrupted.
lots of leads.
Once you're saying switch them off, that's, I guess that we wouldn't want to take off
No,
your
we
monitor
would
at
not,
all.
we wouldn't want to take them off of our monitor.
Um,
That would interrupt the story. Yes.
If you have a smaller patient and it's an adult, but your leads and your pad, can they kind of go, and they go really close to each other? Or do you have to reposition your little dots?
They go really close to each other. They will not interfere with each other.
Dude, I watched a couple of videos to get ready for that, and I was kind of surprised at actually sometimes how close the leads in the pads were. If it was me, I think I'd have a little bit of space, but they were almost right on top of each other, so it should be okay.
I thought it was a surgery where they had that.
Wherever you can get them and where they need to be.
Yes.
She just
Yeah.
said.
We don't have.
Is it a pediatric zone?
It is pediatric.
Oh, pediatric.
Yes.
You have to turn it up more to do an adult if you got a pediatric stuff in it. Do you know what I'm saying?
I do know what you're saying.
I mean, is it advised to turn it up more if you got, if that's all you got is a pediatric?
I wouldn't do it at the pediatric. Now you would start,
Still start it.
there is no real answer to that, but.
Yeah. Just use adult pads for adults and pediatrics.
Well, I'm just saying.
No, if you're in
Because you
that
asked the
situation.
question,
That's all
can
you
you
have.
use
Right.
both?
Yes,
It
yes,
said
yes.
yes, but you started off at the same.
There's an old saying in anesthesia, titrate to effect.
Yeah, that's it.
You do what you need to do to help that. So the answer is yes and no. You start out where, you start out at the adult, but if that doesn't achieve, you go on. Speaking of which, who knows what joules we start out with children? What joules per kilo?
And what's the breakdown approximately from, if you're doing pediatric pads to adult pads? How much does a kid weigh roughly? It's like, it's 30
kilos.
Yeah, so it's what, 70 pounds, something, yeah, so.
Yep.
And if you're on the border, you know, I mean, it doesn't just, if you're not sure, just, you can go with adult pads, that's probably safer.
Considering the size of our children nowadays.
Yeah, exactly. Yeah,
They're
right,
like
so
adults.
peanuts, yeah. I'm gonna do, it's not gonna be very long, but I'm gonna do a few minutes, just kinda did everybody have their rhythm strips in the back? Okay. We're gonna go over a couple. I know we have a pretty seasoned crowd in here, me included. And I guess I'm gonna start off by saying, anybody who's ever thought about doing ACLS and hasn't done it yet, and you're on the border, you're not really sure. I promised myself I would do a minimal amount of back in the day stories, but who remembers taking ACLS, let's say 25 plus years ago? Okay, so you remember they got you in a room, it was three people tested you, you went down all the algorithms, almost to the bottom, you were sweating, I mean, it was an unpoker, it was rough, right? So now it's a lot different. I think American Heart Association is really smart because they said, you know, let's make it a little more user-friendly, let's not beat people up and more people are likely to do it. You know, so now you know, you get in a big circle, you sing Kumbaya, everybody get world peace, everybody gets a puppy. No, not really, but it's a lot better than it used to be, because it used to be kind of rough. So anyway, so I would just say, encourage anybody who's on the edge, just go ahead and do it. So, all right, does everybody have these strips with the boxes on it? Okay. So, all right, so anybody can chime in at any time on the first one. What is that? Okay, so let's say I see this on the monitor. What's the first thing I'm going to do? Look at the patient. Okay, now we deal with healthy people for most part. Okay, but I'm not just going to look at the monitor. Okay, especially now because I'm an epic, right? I'm an epic number one. I'm at the monitor number two, but there's still a patient there. So I got to make sure that my patient, hey, I'm doing great. I'm in sinus rhythm, great. So it's not. What could it be in this? What could it be with this rhythm? My patient's not doing so well. Yeah, it could be PEA, pulseless electrical activity. So number one, check the patient. All right, number two, the second strip. Anybody can chime in? Sinus Brady. Okay. Can anybody, just looking at the boxes really quick, just give me a rough guesstimate of what that ventricular response is? See in the boxes, 300, 150. You know what I mean by counting the boxes? Anybody got a guesstimate? Or it's slow. Okay, it's less than. I think it's less than 30. Right? Yeah, that's pretty slow. Right? Am I right about that? Okay, so like I said, we do healthy people here. So how many times have you seen the guy? He's riding his bike. He falls down, breaks his clavicle, whatever. So I've seen people getting back in the OR. Their resting heart rate is 45 because they're in shape. Okay, but if somebody is, this guy's less than 30. I would say even Michael Phelps has a resting heart rate that's greater than 30. Okay, as far as your stroke volume and stuff. So this person is most likely to be. So I'm only going to treat bradycardia if they're symptomatic. Okay. So like I said, unless even Michael Phelps, I'd say, would be symptomatic with a heart rate of 25 or whatever that is. Okay. So for symptomatic sinus bradycardia, what are we going to do? Anybody chime in? What are we going to give? Drugs? We're going to give? Huh? Yeah. Okay. Atropine. Anyway, we got ACLS people in here. So so atropine. Okay,
Thank you.
all right, atropine.
Dennis would pinch their fingers.
Yeah, atropine. So I can give, I know this is a review for a lot of people, so I can give, so atropine, 0.5 of atropine, up to, what's the maximum I can give? 3 milligrams, some people say 2 to 3 milligrams, okay, because it's a vagolytic, so, right, so you're tapping out the vagus nerve, so 3 milligrams, okay. If I give a couple doses of atropine, it's not working, what am I gonna do?
You're gonna get back.
You can pace or you can do epi, okay. All right, number 3, we're in trouble. Anybody? All right.
It's like a system.
Yeah, it sounds like systolic, yeah. So, they made a big, again, when I was looking at this old stuff, they made a big thing out of, now this is kind of witnessed asystole, but number 1, you monitor's flatline, check your leads, right? Make sure, look at the patient, check your leads, okay, make sure you're not a loose lead. They also emphasize, make sure your asystole is not fine ventricular fibrillation, okay? Because fine VF, you can shock, okay? Asystole, most people, you get to this point, you're in trouble. But BLS, CPR, right? CPR, airway, epi. So then we're moving on. Of course, somebody's getting the Zoll. So, all right, number 4. Atrial flutter, right? Okay. So the main way to differentiate atrial flutter to atrial fib, flutter is usually more regular. Okay. And atrial flutter, you gotta admit, it's kind of a pretty arrhythmia. You know what I'm saying? You got those little soft things, so you got that going. One thing to remember about atrial flutter, it can quickly progress to atrial fib. And most people are usually more stable cardiac-wise in atrial flutter than they are in atrial fib. So your heart rate here is fairly well controlled, not that bad. So you probably just, is a patient symptomatic, same thing. Look at the patient, symptomatic, asymptomatic. Am I going to treat them, or am I going to leave them? Symptomatic, atrial flutter, they're not doing very well. What's the treatment for that? The sync button, cardiovert, okay, sync button, okay. Next one, we just talked about it? Okay. Difference between a controlled atrial fib and controlled atrial fib, ventricular response of, what's the number I'm looking for? If I'm less than this number, I'm controlled atrial fib. If I'm higher than this number, I'm uncontrolled. Come on, Nancy, people help me out. 100, 100, yeah, right? If my heart rate is greater than 100, that's uncontrolled atrial fib. Okay. Less than 100 is controlled atrial fib. All right. Same thing. I'm gonna look at my patient. Are they stable? Are they unstable? So the bottom line is this a rhythm that they can tolerate? Is this a rhythm that needs to be terminated? Okay. And so if my patient is symptomatic in rapid atrial fib, cardioversion, right? And remember we can only get the cardioversion if we go to the defib and then a soft button sync at the bottom. All right. How are we doing so far? Is everybody having fun?
Yeah.
All right.
I'm so intrigued, Joe. I'm so
What's that?
intrigued.
I know.
I don't have my puppy yet.
No, that's true. That's true. Okay. All right. The next one. Classic VTAC. Okay. So, a couple of pearls. Pearls about VTAC. Classic. This is a note for people in PACU nurses. Okay. Classic VTAC is a very ventricular response of what rate? It's right 100, 150, right? That's mostly your ventricular response on VTAC is 150. So, if I'm a PACU nurse, where am I going to set my upper heart rate parameters on my alarms on my machine? Okay, so I'm making sure that if somebody goes into VTAC, I'll probably pick it up. Or a little less, let's say 140, 145. Okay, so that's a little pearl, like, again, back in the day in ICU days, so, so you can probably pick that up. Now, somebody presents in VTAC, it's kind of a three-pronged thing, okay? Number 1, VTAC without a pulse, you treat it the same as VFib, right? VTAC without a pulse is VFib. Okay, so that person is going to be defibrillated. Okay, asynchronous defibrillated, just like we talked about on this machine. It's 120, 150, 200. Okay. Now let's say I see this on my patient in PACU, and you go up to them, and they're like, and they're conscious, but they're like, man, they're short of breath, they don't feel really good, they're lightheaded. Okay, so they're unstable. So that rhythm needs to be terminated. So now we're going to go to cardioversion. Okay, and I believe 50 to 100 cardioversion for VTAC. Okay. Now there is a third scenario which I've never seen. Okay, but people have told me about it. Is you see this, your alarm goes off, you go over to your patient with this on the monitor, and everybody's running up to them, and they kind of look at you like, what's going on? Why is everybody here? So that's a stable VTAC. Okay, so of course you just kind of do your usual oxygen, monitor that patient, and get the all-important expert consultation, right? So that you get your, of course, here the anesthesiologist, cardiologist. But in the meantime, don't stick this guy over in the corner. Say, hey, he's going to be fine. Well, so because he may decompensate and hurt. All right. Next one. This is a fun one. Course refib, or
Move it around.
course refib, or it's a little torsade.
Yeah, that's true.
Could be torsade, and I'm going to say torsade just because it's a fun thing to say. Okay, because it's because torsade.
I've never heard it.
Well, torsade de pois actually is what it is, which is kind of a complex, multifocal V-fib that's just kind of. The only thing good about torsade de pois is the name, because it's fun to say, because you get to throw some French, torsade de pois. Otherwise, again, this patient's in trouble. Okay. Like back in the day when it would be, when a lot of people were on DIG, sometimes it could be DIG toxicity, but you don't really see that anymore. I don't remember the last time I saw somebody on DIG, but right, there used to be, but DIG toxicity was to be in torsade.
So if you're talking French, we're in trouble.
Exactly. So it's fairly refractory to defibrillation, which is a bad thing, of course. So that's another expert medical. By the meantime, everybody's scrambling CPR. You need to get your expert medical consultation in there. And then they're going to say, oh, maybe you need to load with magnesium or whatever. Almost done. And last one. SVT. Yeah, SVT. And then again, stable or unstable. That's the bottom line. Look at the patient. Can they tolerate it? Do I need to terminate it? So of course, if it's stable SVT, and or if it's unstable SVT, again, we're going to cardiac.
I have a question, Joe.
Sir.
I'm going to pull off it. I'm not really familiar with this graph stuff,
Yeah.
but I have nothing to compare it to like a normal reading.
Top one.
The top one.
Is that very normal?
Yeah. We hooked you up.
Okay.
That's probably what you have.
You think of it?
So much slower.
I think I probably want it.
I know this was reviewed for just about everybody.
What are you gonna call that rhythm, Jeff?
Norm?
I know it's reviewed, but if you're like me, I need like the circular learning. I need to revisit things every once in a while.
Yeah.
That kind of gives you an idea when you're coming in the door with this, just kind of what to expect and what to pull out. It's just kind of you're preemptively thinking what somebody's getting ready to tell you. One last thing too before we leave, Tammy, an AED, they're found everywhere now. Has everybody had their hands on one before?
I installed one for the hospital.
There you go. Don't touch it,
Y'all
Joe.
have one? Y'all have a portable one?
Joe, don't touch it.
We've got this.
It's pretty light, Joe. It's pretty light. It is because I carried it
What
down.
was the last strip? Did we do the last SVT?
Yeah.
SVT.
SVT is just, it's kind of a nondescript. I don't like that. I've always really not liked SVT because it's a kind of a nondescript rhythm that originates above the ventricles, right? Supraventricular tachycardia, but it's not. You're not really. You're just saying it's something that's too fast, and it's a small QRS rhythm that's too fast. So it's kind of like same thing. Are they tolerating it? Are they okay? Or is it something that they're unstable and they're going to go out if you don't do something about it? So,
I like it because we get to give a dentist.
that's true.
Joe, I know I'm going to ask a question, but
Yeah.
it's not supposed, say you get the patient having a heart. Is these 1, 2, 3, 7, that's something you expect to read on a monitor when you see coming out the printer? One of these
it's something you don't wanna see.
I mean, what, when you think,
They're all, well, they're not
is there any more versions than this right here?
Yes.
Lots of other things.
Just about a
Billions.
here, go, you put it
Park
in.
lot,
Yeah, but this,
BBC.
yeah, we're just kinda doing a rough, revisiting that.
Think about electricity, Joe.
That's a legit-
I'll sit down with you,
Oh.
show you every time. It is all about conductivity through the heart, and that's what creates those different rhythms and stuff, irritability and different pathways and stuff.
Somebody's watching much for TV, you see it.
Yeah.
That's not good.
Okay.
But in AED, you'll find in every place, they're very self-explanatory. They walk you through every step that you need to do. If someone brings one in, you find somebody in their CPR in progress, you're out shopping or whatever, just know, it'll tell you what to do. You know where to put the pads. All you gotta do is hit the on button, and from there, it'll walk you through. It will analyze the rhythm. It will tell you to shock or not to shock. It is really made for the public, so you would have no issues with it. Just, all you gotta do is hit the on and off button. That is really it. On and off button, and put the pads where you know they need to be, and that is it.
Hey Tim, does this Zoll, pick up a rhythm through the pads just like an AED does?
Yes.
So you don't really have to have the EKG leads on?
You put on pads, really it's recommended that you, in a code situation, you put on
Put
pads
pads
first.
on.
Right.
Yeah.
The difference in the OR is that we're already monitoring the patient, but if somebody's
Right.
fell out in the waiting room,
Right.
it's pads first.
Pads first always.
And this is how, I'm sorry, I don't mean to sound paranoid, but when Tim and I were talking about doing this, we're gonna bring 2 of these down here. And then just this morning I said, so what if somebody falls out in the
Let's just leave
And
it
then I
upstairs.
guess we could run upstairs, but they were like, I hate that, and it's just, and how many times?
We have 2.
2. They're staying right side by side.
They're side by side. One's on top of the pizza cart, one's on top of the
Okay,
cart.
And I know this is a bad thing, but is anybody at church, if you're sitting in church, do you know where the AEDs are? I did it one time, because there may be a situation, you're looking around and you may be it, man, you may be the.
I know that.
Right, yeah, Dennis and I tell you that. You can be the
So,
sole anesthesia.
Cardiac rehab has several outside the door.
So, yeah, so.
Just the biggest thing to remember about the ones on the wall at the hospital versus this one, this will tell you to shock. This will analyze the rhythm and tell you whether to shock or not, but you have to deliver the shock, okay? The ones that are totally automated, put on the pads, turn it on, and stand back.
Right.
Or do chest compress, or do, whatever. But it's gonna analyze the rhythm and deliver the shock.
It will tell you everything to do.
And I don't know about anybody else, but the last time that we did BLS and then ACLS, one of the hardest things for me to do, because remember we talked about there's no ACLS without BLS, is, so you're scrambling, you're getting your pads and stuff, but you gotta keep doing CPR as long as you can, with minimal interruptions. And I think that's kind of difficult to keep that in mind, because you're like, I wanna get the pads on, I wanna get rid of that rhythm, but in the meantime, you gotta perfuse the squash, so you gotta keep, well, it's true, you gotta do CPR. Squash. That's right.
Any questions?
I just had to say, remember that those things are plugged into the wall, so when you go to
Yeah,
the car.
take it away.
Good tip.
You need to unplug it, yeah.
Work the safety tip.
When the adrenaline's flowing.
Fred asked me
Yeah.
the other day, we were talking about the sugar in the car.
Unplug it.
Otherwise you'll get
You'll
whiplash.
get there without it.
Joe will get like you messed up the cord.
Yeah, the ground broke off.
That's right.
And if you notice, we brought the Keith, so if any of you guys wanna practice after we're done, you can have
Can we
at it.
shave his chest?
There's only 3 there,
It's
so.
only
it-
a couple. April pulled most of them out.
Any questions, anything? we
Now,
can answer?
on the pediatric cart, you
Yes.
automatically have the pediatric pads on that defibrillator upstairs.
There are pediatric pads beside it. I'm not sure if they're on it or not, if they're plugged in like this particular one is, so I will check that and
And y'all
let you
check the
know.
dates on the pads when you check the card usually.
Yes.
Those are good for another year.
Yeah, they're generally good for a couple of years.
Usually the pee pads are attached to it, but we also have the adult set also because, any child over 75 pounds, you're gonna have to use it for anyway.
All right. Thank you, guys.
Thank you.